All right, well, we'll go ahead and get started with our first abstract. This is by Mary Seifu on developing a low-cost neonatal gastric suction device for low-resource settings. As she's coming up, just reminding everyone that it's 5 minutes for the presentation, 3 minutes for questions. Please get up, ask questions. We want it to be an informative and engaging session. We have a lot of great abstracts from around the corner and around the globe. Welcome.
All right, thank you very much. Hello, everyone. My name is Mary Seifu. I am a Global Health Engineering Fellow at Rice 360 Institute of Global Health Technologies in Houston, Texas. I have no disclosures except for the fact that I'm not a pediatric surgeon, but I am very honored to be here today. So we did this research because newborns with congenital intestinal conditions in low-resource settings are at extremely high risk of aspiration from preventable deaths due to the lack of proper gastric suction. This is important because we learned that there's currently no method that is affordable, safe, and effective to provide neonatal gastric suction in most low-resource settings. As we all know, neonatal gastric suction, or gastric decompression, is a critical treatment for a variety of intestinal conditions like NEC, gastroschisis, TEF, and atresia. Unfortunately, many low-resource settings where wall suction vacuum units are unavailable, gastric suction is often practiced manually by removing the fluid with a syringe, a responsibility often given to an exhausted mother. You can imagine how unreliable that would be if the mother, for example, potentially falls asleep, and the condition left untreated could cause extremely high risks to the neonate and cause aspiration and preventable death. So our team of researchers and collaborators of clinicians tried to come up with ideal design criteria for proper neonatal gastric suction. This include appropriate low pressure range of about 0 to negative 100 millimeters of mercury, ensuring safety for the neonate with no damage to the stomach lining, ensuring that the power source can facilitate automatic suctioning and a low cost. So in high-resource settings, we know that Salem sump tubes or other double-lumen tubes are often used for gastric suction with intermittent wall regulators, which help maintain that low pressure as well as causing no harm to the stomach lining. The source of suction is usually a medical vacuum supply infrastructure, and this infrastructure helps provide automatic suctioning throughout the hospital in different wall outlets. This infrastructure alone, however, costs hundreds of thousands of dollars, and even in the absence of this infrastructure, portable gastric suction machines may be used, which themselves, however, cost thousands of dollars in the market. So in low-resource settings where this infrastructure and these specialized consumables are often unavailable, clinicians are left to rely on less effective methods of manual syringe suctioning or passive gravity drainage with single-lumen tubes. And although these methods are affordable, they still pose that risk of aspiration. So this is where we saw the gap, and we believe that there's a new tool that is needed to solve this issue. And this is where Rice 360 aims to develop an effective, safe, and affordable neonatal gastric suction device suitable for low-resource settings. So this is our initial prototype. We have the portable suction machine containing the electric pump and all the other electronic components, the collection canister to collect effluent, and the Salem sump tube for gastric decompression. And we believe that our prototype has the potential to meet these criteria. Today I'll be talking about some of the tests that went into trying to evaluate it. So first, for pressure, we tested by varying the pump power to adjustable pressure ranges, and we saw that we could create low, medium, and high pressure ranges ranging from 0 to negative 100 millimeters of mercury. Additionally, we were able also to see intermittent suctioning similar to the current standard of care. For safety, we tested the tubing's adherence to a simulated stomach model to make sure it caused no damage. And the Salem sump double-lumen tube did just that and caused no adherence to the stomach wall lining. Additionally, we had pressure and battery level alarms set in place, and we saw that they could test whenever the pressure was too high or the battery level was too low. For power, we evaluated the electronic supply system as well as the battery life, and we saw that the independent rechargeable battery could last 72 hours on low intermittent suctioning. And this is important because of the multiple power outages that happen a lot in low-resource hospitals. And finally, the cost of making this prototype cost just under $150. So we're excited to show that our device has the potential to meet these criteria. Upon receiving feedback from our clinical mentors, we're looking into focusing on further optimizing this prototype by looking into the safety and power aspects. So for safety, we're looking into more available tubing. We learned from our clinical mentors that Salem sump tubes are not available in many low-resource settings. So we're looking into modifying available tubing or possibly manufacturing new affordable tubing suitable for low-resource settings. And for power, we were inspired by a wearable breast pump. We were considering using a lower power vacuum pump, which will help optimize the battery life, as well as make the device more smaller and compact, which could even further reduce the cost. This video shows a setup of the current benchtop testing that we're doing to evaluate these models. So all of this is to say that we believe there's a huge potential for the implementation of a novel device for neonatal gastric suction that can help provide an effective, safe, and affordable solution for neonates, mothers, and caregivers in low-resource settings. I'd like to thank our collaborators from the UTMB Health. Dr. Naik is here today, who's helped us throughout this process, and our clinical mentors from the Dominican Foundation of Mothers and Infants who helped us throughout this process. Thank you very much. I'll be happy to take any questions or comments.
Are there questions? Please introduce yourself when you come up to the microphone too. Thanks.
My name is Philip. I'm from Nigeria. Thank you very much for this innovation. When you started the talk, I was wondering, is it going to be powered with electricity? Because where we come from, power is very intermittent.
Yeah.
The only question I want to ask is, when is it going to be available for us?
Yes, so it's currently under development. Hopefully in the next APSA presentation, I'll have a real prototype to show you guys. So I'm looking forward to that.
Are there other questions?
I just wanted to make a comment. First of all, great job, Mary. Thank you. Doing a lot of work in low-resource settings, particularly in Africa, I notice all of my colleagues are always ordering things. They have to order all the products from overseas. I think this type of work is really innovative when you think about producing these things in country. And someone like Mary, who's a bioengineer from Ethiopia, is going to go back to her country and try to make some of these things there. And I hope that that's a shift for Africa and other parts of the world that we can think about, rather making things more sustainable and affordable by developing them in country. Thank you.
Yes, absolutely.
So I have one question, which is, I guess it kind of comes off of that, which is, what barriers do you see for implementation in these diverse environments in order to kind of operationalize the local manufacturing of these things?
Yeah, that's one of the biggest issues that we deal with. I would say more of challenges, welcome challenges that we deal with trying to implement new technologies in these different settings, because it's not just about, oh, the technology is great, that's what's needed. There's a lot of steps along the way, including the regulations of the facilities, training the clinicians there in order to understand the technology, and all the steps of making sure that the technology is really what is needed in those situations. So I think since we work a lot with the clinicians there in the different hospitals, and they are telling us what their need is, that helps in the collaboration process. And since they're there in every step of the way, it helps make the implementation process as smooth as possible.
Great, thank you.
Okay, thank you very much.
So our next speaker is Dr. Merit Dessalines from Kajabi Hospital, speaking to us about a case for hypospadias surgery.
Good afternoon, everyone. Thank you for this opportunity to be able to share our work with you. We don't have any disclosures. Hypospadia surgery is associated with high complication rate, both on literature and in our institute. And also, since most of our patients are cash payers, it's also a high cost burden for the patients. As most of you would know, hypospadias is the second most common congenital anomaly in male newborns, amounting to 1 every 300 newborns, and it needs corrective surgery, which is, again, as I initially mentioned, is associated with high complication rate. And the use of standardized protocol both in hypospadias care and other surgeries have shown to improve outcome. Our institution is based in Kenya. It's a tertiary hospital that does average of 70 cases per year, more than half of them being complex proximal hypospadias. This by worldwide standards, qualifies our institution to be a high-volume hypospadia care center. And historically, we used to take care of all our patients as an inpatient, with average length of stay 6 days and average cost close to 160,000 Kenyan shilling, which amounts to around $1,600. And with this care, our complication rate was at 51%. So we hypothesized that the use of standardized protocol will reduce both our complication rate and cost for our patient. And of course, if we do this as an outpatient, it will also significantly shorten our length of stay, which will add to our reduction in cost. We designed the protocol in 3 different parts. The pre-op includes, we emphasized more on nutrition, since about 30% of our patients have associated nutritional deficiency as they present to the hospital. We emphasized on nutrition, and we correct the nutritional state of the patients before we embark on the surgery. And also, all our patients with this protocol won't be admitted pre-op, and insurance and other necessary financial help will be provided for the patients. In the intra-op, we standardized giving the IV pre-op IV antibiotics, which was inconsistent in the previous era, the pre-protocol era. And the pain control was also standardized with the use of caudal block for post-op pain control. And these surgeries are to be done by the most senior trained consultant, be it a pediatric trained surgeon or a pediatric urologist visiting that is present on site. And fellows or residents, trainees, should do at least 50 operations before embarking on doing these surgeries independently. And of course, stent and dressing cares are also standardized. For the post-op, we discharge all our patients the same day, except there is an indication to keep them. We also train our caretakers how to use stent and also the wound care for the dressing. And we do stent removal and dressing removal as an outpatient, and designed a structured clinic follow-ups. We designed and implemented this protocol in January 2020 after training our staff, involved staff in the care of these patients. This gave us a pre-intervention phase from 2015 to 2019, and a post-intervention phase from 2020 to 2022. The results showed that there is no significant difference between the 2 groups, the pre-protocol and post-protocol groups, in terms of age and severity. So there is no statistically significant difference between the 2 groups. With this, our overall complication rate dropped from 51.2%, as was initially reported, to 24%, which is more than half reduction in our overall complication rate. The same was demonstrated for both proximal and distal hypospadia surgery, dropping our complication again by more than half. This was also demonstrated in the specific complication rates that are commonly reported with hypospadia surgery, like ureterocutaneous fistula, dropped from 22% to 9%, which was a significant drop. Also, our cost had dropped from 20,000 non-theater cost to all the way down to 9,000, which is more than 50% reduction again in the cost. This outcome has been heavily influenced by our protocol doing all these surgeries as an outpatient. So this significantly decreases the inpatient cost, which in turn decreases the overall cost for the patient care. So with this, we concluded that it's a simple intervention that we did with the protocol. which gave us a significant reduction of more than 50%, both for our complication rate and also our cost for taking care of these patients. Thank you. This is the aerial view of our hospital.
Wonderful. That looks really beautiful. So just while we're waiting for questions, I'd like to congratulate you on that remarkable reduction in complications and with the reduction in cost. That's really great. Dr. Losty.
Hi there, Paul Losty, Liverpool and England, Bangkok, Thailand. My friend and colleague, Professor Ahmed Hadidi, travels a lot of sub-Saharan Africa, and indeed Africa. He's from Cairo originally, doing hypospadias surgery and indeed wet labs. Have you considered the use of wet labs to try and bring down your complication rate further? Because I noticed that the greatest complication rate, even after the introduction of your program, that's a great progress, is wound dehiscence and urethrocutaneous fistula. And in his wet labs, they use animal phalli, and that gets the teams trained up in those important aspects of watertight closure and skin closure. I just wonder, are you aware of Dr. Hadidi's philanthropic work?
I'm not aware of that particular dressing, but we tried different types of dressing before standardizing to this type of dressing.
Yeah, my point is it might not be the dressing, it may be actually the finer surgical techniques of urethral closure and wound closure. I'm not so sure that your complications are, from what I can see from the tables, it's fistula formation, which in the West is about 2 to 5%, and complete wound breakdown.
So I think, unfortunately, we're out of time. Thank you for that great presentation.
Okay, our next presenter is Dr. Frene Anito, and he'll be speaking on addressing the problem of pediatric central line-associated bloodstream infections at a rural referral hospital in a low and middle-income country. Thank you.
Thank you very much. Good afternoon. My name is Musa. I'm a pediatric surgery fellow from Kijabe Hospital in Kenya. Thank you for the opportunity to present this work. We have no disclosures. Central lines have become a common procedures that are done in pediatric patients in Africa, and along with that comes some of the complications associated with that, and the main one is central line associated bloodstream infections. And we have identified that in our institution, the CLABSI rate is higher than what is reported in low middle income countries, which is about 5 to 7 per 1,000 catheter days, but we had higher CLABSI rates. And we didn't have any standardized protocols or guidelines to guide on how to manage patients with central lines. Why it's important to present this work today is to give insights to physicians working in low middle income countries on how to mitigate challenges associated with central lines in pediatric patients. So we did a multi-year single institution prospective cohort study in all patients under the age of 18 in our institution. On the pre-intervention phase, we collected 12 months worth of data, followed by 5 months of data analysis and intervention, and later followed by 12 months of post-intervention data collection. So the results showed that we had a total of 67 central venous catheters that were placed during this time. 35 of them were in the post-intervention phase, and 32 of them were in the pre-intervention phase. And the majority of patients who had central lines placed were less than 30 days of age. More than 50% of them were neonates. And the primary reason for line placement was parenteral nutrition, difficult IV access, long-term antibiotics, and medication administration. Medication administration here indicates majority of patients had vasopressors, which indicates that in the post-intervention phase, a lot of those patients were critically ill. So on the pre-intervention results, we identified that the median catheter duration was longer for patients who developed CLABSI versus those who did not, 13 days versus 11 days. And the mean catheter duration was about 12 days. And TPN use and catheter duration time showed the strongest association with CLABSI. And our overall CLABSI rate was at 21.2 per 1,000 catheter days, which is significantly higher than what's reported in low middle income countries and much higher than what's reported in high income countries. So we implemented central line insertion and maintenance bundle in order to mitigate these problems. Surgeons showed commitments to maximum sterile barrier precautions. This was a challenge initially due to the financial cost that will be incurred on patients, but later we have agreed to standardize that across the board. Nurse educators were recruited and trained on how to take care of central lines. We also instituted a 5-question test to assess the knowledge, which showed a significant knowledge gap, which was later mitigated by education. And all providers were committed to daily justification of line presence. On the post-intervention results, we found that the median catheter duration was reduced to 9 days, and TPN use showed the strongest association with CLABSI, whereas catheter duration was no longer associated with CLABSI. And the most significant finding was that our CLABSI rate dropped to 12.6 per 1,000 catheter days. So in summary, we did not have any observation of insertion and maintenance best practices, which led our CLABSI rate to be significantly high. Then we instituted central line insertion and maintenance bundles, and on our post-intervention cohorts, we have seen significant drop in CLABSI. So in conclusion, the pre-intervention CLABSI rate was higher than reported in other low-middle income countries. TPN remains to be the risk factor for CLABSI, and implementation of CLABSI or central line care bundle reduces CLABSI in our patients. Thank you. I'll be happy to accept any questions.
Questions?
Hi, I'm Caroline Stevens from UCSF CHESA, and congratulations on this really amazing work. I think it's a great testament to the effectiveness of protocolization in these settings.
Thank you.
For the TPN, I'm curious about your reflections. I'm first of all just very impressed that you have access to TPN and the consistency of that. But I know that frequently there can be issues with stabilization as well as the way it's compounded and stored. And so has your team looked into those factors as a potential contributor to your high association with TPN? Thank you.
Thank you very much for that question. Like you said, TPN, we started using TPN in recent years, and the type of TPN we have is the components, and it will be mixed by our pharmacist and provided to us. That might be why this is significantly associated with CLABSI. We are also working with the quality assurance team of the hospital in order to mitigate those challenges that are causing an increase in CLABSI in our patients.
Hi, Robin Petrozzi, University of Michigan. This is really fantastic. I have so many questions for you because I think it stimulates so much. The question I'm going to ask, though, was one I also wanted to ask your colleague. What is the role of patients and families when you're developing these interventions? Because they're so involved in care. And how, once you get to the end of these with the feedback that you get, would you redesign, incorporating the patients and families as influencers of the interventions? Because I think you have a lot to teach all of us from that.
Yeah, our patients and families are at the core of everything that we do in our hospital. And of course, we involve all the families and patients in every care that we do. And also, in addition to training or educating the nurses on how to take care of these central lines, the family is also involved in that. So I think we have been doing that, but we'll also continue to do that as well. Thank you.
Yes, hello, Frank Margaron from Norfolk, Virginia. Phenomenal work, and very difficult to have that kind of an impact in such a short duration of time. So well done on that effort. My question had to do with kind of the nature of children's care, whether they were co-sleeping with parents or whether they were in a general area with a lot of other children in beds just adjacent or whether they were in private beds? And did you stratify based on kind of location and co-sleeping to the infection rate?
Yeah, thank you. The majority of our patients, like 54% of the patients who had central lines placed were in the pediatric ICU, followed by in the neonatal ICU, which was around 40%. So a total of 94% of those patients were in the pediatric ICU or in the neonatal care intensive care unit. So only 6% were those in the pediatric floors. So I don't think that was mainly a factor contributing to CLABSI, as opposed to these other factors that I have mentioned.
Thank you.
Thank you. I think we'll move on. Thank you.
So our next presentation will be the outcomes of ambulatory pediatric surgical care provision in Kakuma refugee camp during a measles outbreak, presented by Dr. Nemekasiji.
Good afternoon, and thank you for the opportunity to present our work from Kakuma refugee camp. We have no disclosures. 100 million people are displaced globally as a result of conflict and also climate disasters. A significant proportion of them are hosted in sub-Saharan Africa, including Kenya. Kenya hosts about 550,000 refugees, and 230,000 of them are in Kakuma refugee camp in Turkana, northwestern Kenya. Turkana and Kakuma refugee camp experienced multiple measles outbreaks in 2023. By July 2023, 295 measles cases had been reported in Turkana County, and this was a result of an influx of refugees from South Sudan who did not have access to measles vaccines. Our initial approach was to delay pediatric surgical care provision up until these outbreaks had ended, but these outbreaks never really ended, and we needed to find a solution for reactivating and restarting surgical services. And so we developed an ambulatory pediatric surgical protocol to minimize pediatric surgical patient exposure to measles patients. At this time, we had about 20 hospitalized measles patients. This protocol included the measles vaccine, the WHO surgical safety checklist, an occlusive dressing with Tegaderm that the patients kept when they went home, and pain control with acetaminophen, Tylenol, that the parents gave at home. And our objectives were, number one, to assess the feasibility of implementing this protocol in a refugee setting. The usual practice is to admit all patients, including patients that are coming in for simple procedures, such as hernias, and to keep them postoperatively for one night following the procedure. So this was a change from our usual practice. And our second objective was to assess postoperative outcomes of ambulatory pediatric surgical care in Kakuma refugee camp during a measles outbreak. In terms of our methods, we retrospectively reviewed patient charts to determine demographic information, their diagnosis, the procedures that were done, and postoperative outcomes, specifically the morbidity and mortality related to this intervention, and also the incidence of measles in our surgical patients. We calculated means, ranges, and proportions, and also confidence intervals to determine significance. In terms of results, we conducted a total of 28 ambulatory pediatric surgical procedures in 26 patients. The mean age in this cohort was 5 years old. Our youngest patient was a year old, our oldest 13 years old, and they came from South Sudan, Burundi, Somalia, and the Democratic Republic of Congo, countries that are all in conflict. All our patients received their measles vaccine, bringing our preoperative measles vaccine coverage rate to 100%. And in terms of cases, the procedures that we did, these were simple cases. There were inguinal hernia and hydrocele repairs, and also umbilical hernia repairs. In terms of postoperative outcomes, we had no peri or postoperative deaths, no surgical site infections using the occlusive dressing with Tegaderm, no recurrences, and none of our patients contracted measles. These are our surgical wounds at 7 days when we removed the occlusive dressing. And also at 9 months, we saw all our patients a couple of weeks ago to confirm that they were doing well and they had no complications. In conclusion, there is a rise in the incidence of vaccine-preventable childhood diseases, including measles, and this is happening here in the US as well. The CDC has reported 10 outbreaks in 2024, including here in Arizona. Second, ambulatory pediatric surgical care can safely be conducted in a refugee setting. We're able to show this, and our practice has changed as a result of these results. And finally, ambulatory pediatric surgical care can safely be conducted during a measles outbreak by maximizing measles vaccine coverage among surgical patients and also minimizing their exposure to measles patients by making sure that they don't interact with hospitalized patients. In terms of next steps, we continue to advocate for the inclusion of pediatric surgical care in the essential health package in refugee settings. And we're also working on health insurance coverage schemes to achieve financial sustainability and also financial protection among pediatric surgical patients. I'm thankful for my team in Kakuma and Turkana, and also very grateful for our partners, including UNHCR, the Ministry of Health, IRC, and the Rockefeller Foundation. Thank you for your attention, and I'll take any questions.
Great, thank you.
Thank you for sharing your experience, Jackie Saito. I'm at Children's National Hospital. You know, I think you commented a lot on the surgical protocol that you took to try to minimize the risk to your patients and to continue the operations. I mean, I think that we experienced something similar in the United States with COVID, where there was a period of time where elective surgery was postponed, and then it became apparent that we couldn't do that indefinitely. My question for you is, you know, from an infection control standpoint, can you give us a little bit more information about the hospital and what measures you could take or couldn't take to try to isolate the populations, you know, those that had measles, and to keep your ambulatory patients safe?
So that's an excellent question. So there was a physical separation. So we had our surgical patients come directly to the pre-op area, so they never actually made it to the inpatient area because that's where the measles cases were located. And then we made sure that they went home that same day. So that was also a separation in terms of the time that they spent there. They were physically separated, and they were also protected. They all got their vaccines beforehand. And staff members also, we also made sure that we were all vaccinated.
Thank you so much.
You're welcome.
Wonderful. Was there any challenges to kind of implementing ongoing kind of isolation, or what was your guidance to families and interaction with families about kind of keeping their children safe around the times of their surgery?
So that's an excellent question again, and the response is quite similar. So we kept them physically separate, and because the inpatient area is quite crowded, and it would have been very, very difficult to keep our surgical patients who are fairly healthy. They're just here for their hernia, and they're otherwise healthy. It would have been very, very difficult to keep them separate from the hospitalized patients. So we basically didn't give them a chance to interact with the inpatients at that point.
But when they went home on that same day, was there guidance? I imagine they have siblings and other young kids around them that they could get measles.
Yeah, so the siblings are healthy. Awesome. They were not hospitalized. We gave parents clear instructions in terms of what to do with the dressing. So the dressing needed to stay on until their postoperative visit. And then also in terms of pain control. So we instructed the parents to give Tylenol with every meal for 48 hours to ensure that there was adequate pain control. And we didn't get any bounce backs, and they all did very well.
Super, and I applaud your long follow-up in that challenging setting. Thank you so much for your talk.
Thank you.
Our next presentation is Neighborhood Disadvantages Associated with Decreased Healthcare Access in Pediatric Appendicitis, a multi-site NISQIP Pediatrics Retrospective Cohort Study presented by Caroline Stevens.
Thank you for the opportunity to present our work. We have no disclosures.
Neighborhood-level social determinants of health, or SDOH, have previously been found to be associated with appendicitis outcomes in children. However, these previous studies have almost exclusively focused on rates of perforated appendicitis. In addition, the majority of these studies have been single-center in nature, and for multi-center studies, they have largely utilized zip codes for geographic classification. However, zip codes can be highly problematic as they are inconsistent, change regularly, and may contain populations of tens of thousands of individuals. We sought to characterize the association between neighborhood-level SDOH and access to appropriate pediatric surgical care for appendicitis in a multi-center study. We undertook this work because the creation of interventions to address these disparities requires a clear understanding of the specific communities that are at risk. And we are presenting it today because our findings demonstrate the pervasiveness of these disparities, and the multi-center approach improves the generalizability of these findings. So we conducted a multi-center retrospective cohort study of children less than 18 who underwent surgical treatment for appendicitis from 8 ACS DISQUIP pediatric hospitals between January of 2016 and December of 2021. All patients were geocoded and linked to 3 neighborhood-level SDOH indices at the census tract and block group levels, which are superior to the zip codes. This included the Social Vulnerability Index, or SVI, the Area Deprivation Index, or ADI, and the Child Opportunity Index, or COI. Notably, Child Opportunity Index was inverted to maintain directionality with the other indices, and this meant that all patients with lower scores were considered to be more advantaged, and those patients with higher scores were considered to be more disadvantaged. We looked primarily at 2 outcomes: access to pediatric surgical care and radiation stewardship. For access to pediatric surgical care, we considered whether patients presented with complicated appendicitis, as well as whether they presented with sepsis or SIRS. For radiation stewardship, we considered whether a patient was diagnosed with appendicitis with a CT without a prior ultrasound or MRI. We utilized mixed effect multivariable modeling to assess these associations and directed a cyclic GRAS to identify potential confounders that may impact these associations, as you can see here. When we considered radiation stewardship, we additionally included obesity, as this may impact the decision to obtain a CT for a child. Overall, our entire cohort consisted of 8,160 patients with an average age of 11 years. 9% of patients did have comorbidities, and 18% had a BMI greater than the 95th percentile. We had a highly diverse cohort with 25% of Hispanic ethnicity, approximately 8% who were Black or African American, and 5% who are Asian, mixed race, or other race. Overall, our patients were largely from the surrounding area of the hospitals where they received surgery. However, 51% were transferred in the course of their care. Additionally, 27% had a complicated appendicitis, 64% presented with sepsis or SIRS, and 26% had a pre-op CT without prior ultrasound or MRI. We found, when we looked at the access outcomes, that for every decile increase in the SDOH index, there was a 4 to 5% higher odds of complicated appendicitis. Additionally, for every decile increase in SDOH, we also found there was a 3 to 5% higher odds in presenting with sepsis or SIRS. These results were even greater associated with radiation stewardship, so you can see that there was a 8 to 14% higher odds of undergoing a CT without prior ultrasound or MRI for every decile increase of SDOH. And when we stratified these groups into those with uncomplicated appendicitis and complicated appendicitis, we noted that there were similar associations and effect sizes. Overall, this data suggests that there's a significant association between neighborhood-based SDOH and access to surgical care for children with appendicitis. This means that patients who are socioeconomically disadvantaged, as reflected by these indices, present with more advanced disease and more frequently have sepsis and SIRS. Additionally, these patients may also be exposed to greater rates of ionizing radiation. Our study is limited by the retrospective design, which limits the assessment of causality and potential underlying driving factors. Additionally, all participating sites were tertiary care centers, which limits its generalizability. And lastly, we were unable to assess the impact of language concordance on these findings. Overall, this suggests that there is a great need for interventions to ensure optimal surgical care for children of all sociodemographic backgrounds. And interventions that could be considered would include outreach to high-volume referring centers, community education regarding the availability of pediatric resources, and the creation of standardized processes for the evaluation of abdominal pain to mitigate implicit bias. Thank you.
Maybe I'll start off with a question, and I think you kind of touched on it a little bit on the last slide, but do your findings reflect really problems with physically, accessing the care, or a lack of awareness or understanding that's leading to delayed presentation? And then therein, what would be those community-based education interventions or something like that that could be implemented to help improve outcomes?
Thank you for the question. I think it's a really excellent point and question that we need to really understand what's happening at the community level and for these patients. There has been one prior study that qualitatively did try to look at why patients were presenting late and had delayed presentations, and actually found factors at each of these levels, both in terms of family understanding for how to access care and the interactions that they had when they presented to care, both in primary care clinics, urgent care clinics, and the emergency departments. And I think this gets at how we need to consider these multiple factors when we are looking at this issue. I also, as someone who dabbles or has a component also of global surgery, think we could really apply and utilize the models that we've used to assess delays in care in those settings, such as the 3 delays model, which includes delays seeking care, receiving care, and reaching care. And we could also utilize that model to consider and understand the disparities in our own setting.
Great, thank you.
Hi, Lindsay Wolf, Arkansas Children's. Thanks for that presentation. I was wondering if you could tell us how you defined sepsis and SIRS, because 64% seems like a lot of your population. And just having one SIRS criteria might not really represent a complicated appendicitis.
So NISQIP actually includes a variable that predefines this, which is really wonderful. And it also means that the SCRs actually specifically look at this and pull it out. And it defines and requires that people have 2 factors. So for instance, having an elevated leukocyte count and being tachycardic. But it's a specific variable that's related to appendicitis that all the SCRs who perform the NISQIP abstraction look for, which is really helpful and wonderful.
I think we have time for one last question.
Hi, Robin Petrozzi, University of Michigan. When you were looking at if they were transferred or not, did you control for that when you looked at those that had complicated appendicitis or those that received cross-sectional imaging first?
So we do have a slide related to that, if I can advance forward. Or I don't know if it's letting me. But we did look at this. So we looked at proximity to hospital as one of the primary factors related to appendicitis care, as well as specifically actually for radiation stewardship. We adjusted for that and still found significant differences when we adjusted specifically for transfer status, which is kind of what we were considering in this. I also did a separate analysis where we stratified for transfer status, because one of the other components of this question is who is coming to what hospitals and where these patients present. And you see differences when you adjust for transfer status versus when you stratify for transfer status. So when you adjust for it, these associations are still quite significant. But when you stratify, we see that, for instance, the issues with radiation stewardship are primarily at outside hospitals. This likely reflects the fact that patients from more disadvantaged socioeconomic backgrounds are actually going to outside hospitals before they're transferred for care.
Great, thanks.
Great, thank you.
Great. And our next presenter is from Children's Hospital LA, Dr. Michaela O'Gwen, presenting on pediatric trauma mortality and how it differs by neighborhood opportunity level. Thank you.
Hi, everyone. Thank you for being here today. We appreciate the opportunity to present to you all. We have no disclosures. Traumatic injury stands as a paramount contributor to pediatric mortality, yet there continue to exist limitations in the understanding and acknowledgement of factors associated with mortality and pediatric trauma. Recent findings and studies have indicated that neighborhoods are associated with significant resource changes, as well as they influence the childhood health, their outcomes, and injury susceptibility, with disadvantaged neighborhoods having been linked to an increased rate of traumatic injuries. Our objective was to characterize pediatric trauma mortalities and the distribution across neighborhoods. We hypothesized that most traumatic mortalities would be due to motor vehicle collisions or pedestrian injuries. We conducted a retrospective study using the County Trauma Registry, which includes 15 different trauma centers. We evaluated and identified trauma mortalities in children over 11 years. In addition to the evaluation of our cohort at large, we stratified based on home childhood opportunity index. Childhood Opportunity Index, or COI, is a continuous composite measure that evaluates 29 different indicators. These indicators span from environment and health factors, socioeconomic factors, as well as access to healthcare and education. In total, there were just under 600 traumatic mortalities during this time frame, with 513 being included within our study. Within our cohort, the median age was 14 years, and 70% of our patients were male. Regarding to injury mechanism, we found that 37% of these were due to assaults, while pedestrian injuries accounted for 25%. For our patients, the ED emergency department disposition was death in half of our cohorts. Moving on to stratify based on Childhood Opportunity Index, we use the patient's home zip code to determine this. You can see the different shades of gray representing the different quintiles, while the black circles represents the number of children having mortality within that zip code. You can see the proportion of pediatric traumatic mortalities within each zip code and quintile does differ, with a predominance occurring in our within the lower opportunity neighborhoods. Assessing these based on the specific quintile compared to the county population is clearly demonstrated in this graph. You can see that the distribution of LA County children remains relatively consistent across all 5 levels of neighborhood opportunity. Meanwhile, the gray bar representing the proportion of mortalities within each quintile is very different, meaning the very low opportunity index represented 47% of pediatric trauma mortalities within our study. Meanwhile, it only represented 25% of the county childhood population. Further differences were noted whenever we looked at the mechanism of injuries, with assaults accounting for a greater proportion of mortality within the low and very low COI quintiles, while self-inflicted injuries had increased and were more predominant within the moderate, high, and very high quintiles. Additionally, we found that firearm injuries were more frequent within our lower opportunity neighborhoods as well. Our findings demonstrate that mortality among traumatically injured children occurs disproportionately across neighborhoods, with a greater proportion occurring in children of lower opportunity neighborhoods. While assault and pedestrian injuries were common mechanisms of mortality, they had distinct differences in the distribution. Ultimately, we identified the children most vulnerable to traumatic-related injuries and mortality, as well as the relationship between injury mechanism, outcomes, and neighborhood characteristics. Understanding the relationship can be used to better inform pediatric trauma care. And given that trauma centers typically care for the most severely injured children, they're well positioned to provide community-based collaborations and injury prevention initiatives that are based upon the needs of each community and tailored to those communities. I want to thank our institution and our trauma program, as well as our co-authors on this project. I'm happy to take any questions.
Thank you for your talk. Just to, I guess, UK perspective, we see a worrying shift in knife crime or knife stabbing injuries in the pediatric population. I guess with your assaults, you're referring to firearm mainly rather than knife crime. Would that be the case?
Yes, sir. So assaults included both any type of sharp weapon, firearm injuries, as well as physical assaults.
So you've got very powerful demographic information there for your legislators and things like that. And I guess that's where you need to go with this information, isn't it?
I think so, and kind of like what was alluded to in the previous presentation is that really fully understanding and breaking down and having granular information can help us better inform policies and advocate for these vulnerable children.
Thank you so much. Great talk. For this, you only looked at mortalities. Did you also consider looking at number of assaults or injuries? Because it may, the fact that there's higher mortalities in those areas may also reflect the fact that there's just more assaults in those areas, which has been shown in other big cities such as Houston and Chicago. And then my second question was, are there different EMS services that are in those areas than they are in the high-income areas, or is it kind of the same centralized EMS service? Because with 50% deaths, you assume that those are deaths at the scene, and why isn't EMS bringing those into LA County, which is very central?
Yeah. To answer your first question, both are phenomenal questions. Our group has actually looked at the distribution of assaults and those types of injuries, which also correlate to our findings related to mortality. Deaths that occurred at the scene actually are not included within this registry, so would not be impacted by EMS transport.
Yeah, but 50% of them were pronounced dead in the ER,
Correct,
which means
yes.
they basically did die at the scene. They just brought them in.
Yes, there was some sign of life that prompted transfer to the facility. Yes, correct.
So is there different EMS services in LA County, or is it centralized? Is there disparities in that?
So my understanding is that there's a centralized process that designates what facility they would go to in relation to where they pick up the child. I don't have specifics on that. I can figure that out and get back to you, though.
Okay, thank you.
Yeah, of course.
Wonderful. Thanks, Dr.
Thank you so much.
Our next presentation is Child Opportunity Index and Gastroesophageal Reflux Disease Management Analysis of Socioeconomic Status and Anti-Reflux Surgical Procedures. Our presenter is Tania Janelle.
Hi, thank you so much for having me. I'm excited to present our work on behalf of the Eastern Pediatric Surgery Research Network, looking at COI, which my colleagues have done an excellent job of setting me up for. So thank you. There is a wide variety of practice nationally in medically refractory GERD and a paucity of evidence in the literature to guide management. Children are already a vulnerable population, and there are even further challenges that need to be addressed, including access to care, if we're ever to reduce the gap in healthcare disparities. With this in mind, we incorporated the Child Opportunity Index, which evaluates the quality of resources available to a child, looking at how the score would affect surgical management, and with lower scores indicative of social vulnerability. The purpose of our study was therefore to look at post-operative healthcare utilization following anti-reflux surgery in children with severe GERD, with the primary outcome being the number of unanticipated healthcare visits in the first post-operative year. The secondary outcome looked at the Child Opportunity Index and its impact on choice of surgery. This is a multi-center retrospective study on behalf of EPSN that included 10 years of data over to about 10 hospitals that participated using a REDCap database in evaluating unplanned visits. We specifically excluded GJ changes and J-tube changes and any sort of planned post-op visit. We did build a multivariable regression model using hospital as random effect to evaluate this post-operative visits that were unanticipated. With our chart review performed, we had about 1,100 patients, the majority of which were Nissen fundoplications, the remainder being post-pyloric tubes, with 30 patients lost to follow-up in the Nissen population, with 974 left for multivariable analysis. This slide breaks down the characteristics of our study population. When we evaluated the demographics, we found no difference in age or weight when we looked at all the patients. When breaking down the surgical procedure, NICU babies and children whose families had public insurance had a significant difference in choice of procedure and tended to undergo Nissens. There was also a significant difference in race, and children that had a lower COI were actually more likely to undergo Nissen fundoplication. We then evaluated the preoperative symptoms and comorbidities and found that those that had vomiting and aspiration pneumonia preoperatively tended to undergo post-pyloric tube placement when compared to children that presented with failure to thrive that underwent Nissens. Interestingly, there was no difference in choice of procedure based on comorbidities as outlined here in these categories. When we performed our multivariable analysis, there were many factors that showed statistically significant differences, with the primary outcome being unanticipated healthcare visits. We noted that a positive number here was a direct correlation to the number of unplanned visits. So children that had post-pyloric tubes had public insurance, preoperatively presented with pneumonia or vomiting had an increased number of unanticipated healthcare visits in the first year. Of note, children that had neurological disease underlying also had increased number of visits. When we looked at age in the COI, we noted that children that had a higher COI and children that were older correlated with fewer visits. And lastly, when we evaluated children that had a NICU stay or children that had cardiac disease, we noted that they had fewer unanticipated visits, likely due to their length of stay. These findings are consistent with previous research that shows that COI correlates to increased need for pediatric readmissions and emergency room visits. We showed that post-pyloric tube placements had an increased number of unanticipated visits, which is reflective of the significant healthcare burden these families go through. It's important for us to think about the choice of operation that should be carefully weighed to improve outcomes after hospital discharge. The limitations of our study include its retrospective nature and, of course, some loss to follow-up, including mortalities and conversion to a second treatment. There is some institutional variability due to the design of the study, which lends itself to some biases as well in terms of operative choice. Thank you to everyone involved, particularly Columbia serving as the lead site, my PI, Dr. DeFazio, and everyone at Langone who has supported me, as well as EPSM. Thank you so much.
Questions?
Eric Hansen, Phoenix Children's. Thanks for showing this. This is interesting because there's your point about variability and the bias drives it heavily. When a GI doc actively obstructs the ability to get a Nissen, will change their outcomes, right?
Yes.
So my question is, what they're arguing then is that the complications from those who get Nissens are more devastating than having to come back to the ER and get your post-pyloric tube repositioned, right? And so do you have data about the kind of severity of complications in those groups that might instruct kind of what we do?
Yeah, we had actually a previous analysis that looked at some complications in the first 30 days that included mortality, return to OR, infection, things of that nature, and actually found that children that had post-pyloric tubes were more prone to those complications. And most of the time they came back for tube dislodgement and infections, leakage around the tube, things like that, whereas the children with Nissens came in with nothing of that nature and had fewer visits as well.
Other questions? I might have missed that, but how did you determine or define what was, planned versus unplanned? That's 1,000 patients, so what was?
Oh yeah, it was quite the endeavor. So we looked at the reason for the visit and mostly looked at emergency room visits. And if there was a clinic visit where a patient was referred to the emergency room, we counted that as unplanned because nobody plans to go to the emergency room. They were sent in for a problem.
Okay, so then I guess the corollary to that, or how many of those unplanned visits were because of a concern for a substantive issue that, really didn't require a visit? So in other words, would more comprehensive kind of post-op education targeting those populations help mitigate those unplanned visits?
Yeah, I do think so, because most of the unplanned visits were related to tube issues, as I mentioned, dislodgement, any sort of leakage or malposition of the tube, or the tube would fall out, for example. And so I think that tended to be the main issue. So if we're able to educate these families on what to look for and how to mitigate those issues, it would be beneficial, certainly.
Great, thank you.
Thanks.
Our next presentation is Dr. Derek Crinnock from University of Arkansas in Little Rock, and he's presenting to us on patient factors associated with access to outpatient pediatric general surgical care in a rural state. Thank you.
Good afternoon. My name is Derek Crinnock, a general surgery resident from University of Arkansas for Medical Sciences and current pediatric surgery research fellow at Arkansas Children's Hospital. Thank you for the opportunity to discuss patient factors associated with access to outpatient pediatric surgical care in our rural state. We pursued this study as pediatric surgical services are becoming increasingly specialized and localized and focused in metropolitan areas, creating significant disparities with access to care in children that live in more rural settings. Our findings we are presenting today are an important reminder of what should be considered as we develop interventions to combat inequitable access to care. We have no disclosures. Access to care is defined as the ability to receive care when needed without undue burden or delay. From a surgical perspective, this has increased importance when you consider many surgical conditions may become more complicated if not treated in a timely manner. Given that pediatric surgical services are becoming localized to metropolitan areas, children in rural areas are at an increased risk for delays in diagnosis in both acute and elective surgical problems. While distance is an important factor in access to care, several patient factors like race, ethnicity, and socioeconomic status have also been shown to contribute to health disparities. A significant portion of Arkansas is considered rural, with many patients traveling far distances for access to care. Given that pediatric surgery in Arkansas is localized to 3 outpatient clinic sites and 2 operating hospitals, we sought to understand factors associated with inability to access to care among children referred for outpatient pediatric surgical evaluation and the impact on potential delays in care. We performed a multi-site retrospective cohort study at a tertiary referral facility. We queried the medical record for all patients less than 18 years old, referred for an initial outpatient pediatric surgical evaluation between November of 2017 and July of 2022, with follow-up data collected until July of 2023. Patients were excluded if they had a previous encounter with pediatric general surgery or had a referral and underwent an operation without a preceding clinic appointment. Primary outcomes of our study included whether a patient received an appointment, whether the appointment was completed, and whether the patient underwent an operation, with secondary outcomes measuring the time from referral placement to clinic appointment completion or operation. Delay to clinic appointment or operation was defined as 1 standard deviation above the mean length of time from referral placement to appointment or operation. We included 5,270 children in our study, with all patients referred for outpatient pediatric general surgery evaluation having an appointment scheduled. 85% of the cohort completed their appointment within 1 year of referral, and of those, 83% completed without cancellation or missing an initially scheduled appointment. 40% of the cohort underwent an operation. On the left, the map of Arkansas displays the distribution of patients that did not complete their appointment. Each red dot represents the clinic locations, while the blue dots correspond to an individual zip code and the specified number of patients that came from that zip code that did not complete their appointment. While patients were distributed across the state, there was a predominance in the central and southern portions of Arkansas. On regression analysis, those patients who identified as African American or Black, Hispanic, or lived greater than 100 miles from a clinic site were less likely to complete their clinic appointments, while those that were privately insured were more likely to complete their clinic appointments. The average time from referral to completed appointment was 22.5 days, with the delay being considered any appointment after 56 days. There was little variation in time to appointment between those patients that underwent surgery and those that did not. Notably, the geographic distribution of those patients who had a delay in appointment were clustered around urban centers. And on regression analysis, patients who identified as African American or Black were more likely to have a delay in appointment than those who identified in white. The geographic distribution of the African American or Black patients with a delay in appointment was predominantly clustered within 25 miles of the main children's hospital. For the overall cohort who underwent an operation, the average time from referral to operation was 81.5 days. Due to some surgical conditions like pectus deformities or undescended testicles having an anticipated delay to an operation, we elected to exclude some patients from analysis from time of referral to operation. In the cohort excluding these patients, the average time from referral to operation decreased to 75.5 days, with the delay in operation being defined as greater than 206 days. All patients referred for an outpatient general pediatric surgical evaluation obtained a clinic appointment, with the majority of patients completing their initially scheduled appointments. Several patient characteristics impacted clinic completion, with those identifying as African American or Black being associated with a delay to appointment. While distance was an important factor in clinic completion, it did not impact the timing of appointment or to operation, and most notably, the patients that had a delay in appointment were clustered within 25 miles of the children's hospital. Several other inherent patient characteristics created the disparity we observed. As we look toward improving surgical management for the children of Arkansas, we must consider several factors, and it's not just those that live far away that are having difficulties accessing care. Thank you.
Thank you for that presentation, Jackie Saito from Children's National. A lot to unpack, and more questions generated by your initial study. So thank you for doing that. My question is, and recognizing that this is just the start, is understanding those patients that didn't need an operation. Do they even need to see you? And what is the opportunity there to even minimize the burden further to families by not even referring those that may not really require surgical intervention? Thank you.
Right. And yeah, some of those patients could be, patients that are referred for evaluation of an inguinal hernia that when we see them, they end up not having one, or, an umbilical hernia that eventually closes. So there are different patient conditions that could contribute to them not needing an operation, or patients in the older population of pilonidals. We're rarely doing operations for pilonidals now, and it's more just laser hair removal.
Great. I was curious as to what you think happened to the patients who never completed the appointment. Do you think the condition resolved, or they accessed care elsewhere, or because it seemed like a reasonably large proportion that never actually completed that initial appointment?
Yes, it was about 15%. And it's possible that they were referred for a condition that the parent didn't necessarily find as important to be evaluated, or the parent decided that they wanted to wait and refer later. So not exactly sure, but that's one potential.
Just a quick comment, if I may come in that last point. Do you not have a callback service for non-attenders that you could have a coordinator to ring the families to find out why they're not attending?
I'm not aware that they reach out to find out why, but I know they do have, telephone follow-up, or at least send letters to say, we're sorry we missed your appointment. We'd be happy to reschedule.
Great. Thank you so much.
Thank you.
Okay, our final presenter is Raphael Klein-Cloud, and the presentation is on racial and ethnic disparities in pediatric firearm deaths persisting in 2022.
Good afternoon. Thank you for your time and attention, and I'll be speaking about the racial and ethnic disparities in pediatric firearm deaths. Dr. Sathya is funded by the NIH, but this doesn't have any bearing on the design or conduct of the study. It's important to investigate the mechanisms leading to firearm mortality in minorities, and the epidemic of firearm violence that we see in the United States has had an extraordinary impact on this vulnerable pediatric population, particularly those that are underrepresented minorities. Pediatric patients need protectors and advocates, and understanding the aspects of firearm violence that predominantly contribute to these mechanisms has implications for violence interruption at a community level, as well as for policy and legislation. In 2019, firearms surpassed motor vehicle collisions as the leading cause of death in this population, and our prior research showed that this trend continued through 2021. There are significant racial disparities, with Black children dying from firearms homicide at a rate 11 times greater than that of white children, and white children were predominantly affected by firearm suicides, and our aim was to characterize these trends through 2022. We performed a retrospective database study and queried the CDC Wonder database for firearm mortality in patients aged 0 to 19, spanning 2019 to 2022. We looked at the crude mortality rate, which is defined as the number of deaths per 100,000 persons. This enables us to compare across these wide demographics. In 2022, the overall crude mortality rate due to trauma decreased to 19.4 from 20. And you can see in this figure, we're comparing the leading causes of death. The overall rate of firearm deaths decreased from 5.8 in 2021 to 5.6 in 2022. However, firearms continue to be the leading cause of death in 2022. The second leading cause of death continues to be motor vehicle collisions. When we look at firearm deaths, comparing them by intent, despite the slight decrease in deaths due to firearms, there was an increase in the number of firearm homicides, continuing this upward trend over the last few years. The number of suicides by firearm decreased, with a crude rate of 1.5 in 2022, down from 1.7 in 2021. And you can see the rates for unintentional and undetermined remain low and stable. Here we compare firearm deaths by race, and we find that black children continue to be disproportionately affected, with a crude mortality rate of 18.6 in 2022, nearly 3.5 times higher than the next highest crude rate, which is in American Indian and Alaskan Native children. Firearm mortality rates in white and Asian children continue to be lower and relatively stable. In the figure on the left, we compare the rates of firearm homicide by race, and we see the increase in firearm homicides in 2022 was driven in part by an increase in white children and also in American Indian and Alaskan Native children. On the right graph, we compare the rates of firearm suicide. The crude mortality rates due to suicide continue to be highest in the American Indian and Alaskan Native population. Despite the overall rates of suicide decreasing, there was a notable increase in the rates of suicide in black children in 2022, continuing this trend since 2019 and before. For the first time, crude mortality rate due to firearm suicide surpassed that of white children, which showed a decreased crude mortality rate in 2022. Looking at firearm mortality in Hispanic children, there was an increase in crude mortality rate in Hispanic children in 2022, continuing an upward trend since 2019. And analyzing by intent in Hispanic children, 2022 also saw an increase in crude mortality due to firearm homicides and a decrease in mortality by suicide. In 2022, racial disparities persist in pediatric mortality due to firearms. Black children continue to be disproportionately affected. Notably, we have seen an alarming trend of increasing rates in firearm suicide in black children over the last number of years, and this rate has surpassed that of white children for the first time. Further, American Indian and Alaskan Native children are also disproportionately affected, with firearm mortality rates second highest overall due to suicide and homicide. And there's a paucity of research into firearm violence in this population. We've already begun our analysis of current epidemiologic data regarding pediatric firearm violence and looking at 2023 and beyond. But as a medical society, we must redouble our efforts to implement preventative measures. Our group at Northwell presented 2 talks on Thursday on our work with firearm violence risk screening and how laws limiting child access to firearms are associated with decreased mortality. In addition, screening for depression and suicidal ideation and firearm safety education are paramount. And finally, firearm violence doesn't happen in a vacuum. Efforts to ameliorate the socioeconomic inequalities that plague underrepresented minorities in this country will contribute significantly to addressing the disparities apparent in pediatric firearm violence. Thank you very much.
Questions? So 0 to 19 is kind of a big spread in age. So out of curiosity, were those disparities around ethno-racial lines consistent even for the younger kids, say like 10 and under, or just the adolescents?
Mm-hmm. So when you look at the smaller age ranges, because of the CDC Wonder database limitations, they don't publish the actual crude mortality rates if there are fewer numbers. And so a lot of times we can't do those analyses. The older adolescents are the ones who are predominantly affected by the firearms, but we would probably need to look at another database in order to do that analysis.
Okay. And then you listed some potential measures we could take. Obviously, to say gun control is a thorny issue is an understatement and probably not a viable option. Which of those that you listed do you see as being the next best step in terms of low-hanging fruit for implementation?
Yeah. So I think that when you talk about the changes that you need to make in order to decrease rates of firearm violence, it's such an umbrella term that we need to look at what the specific cause is of each type of mortality. So preventing suicide is very different from preventing homicide. And I think paying special attention to those key differences is really important, and focusing on the education of families in terms of gun storage and safe storage and things like, and access is a really accessible way to do that on the front lines every single day, every single patient, and that's what we're doing at Northwell, raising firearm safety awareness. We Ask Everyone initiative.
Excellent. Thank you so much.
Thank you.
This concludes our session. We want to thank our presenters for amazing work and great presentations, and the audience for your participation. Thank you.